So I'd like to move to the next presenter, Professor Kaoru Tsuchiya. Uh, you know well about her, but shortly I'd like to introduce her. She's now Director, Department of Gastroenterology and Hepatology, Musashino Red Cross Hospital. And she has graduated Gunma University in 1998, and from 2020, she took present position. And her topic is new treatment strategies for unresectable HCC, the positioning of lenvatinib in real-world practice. Professor Tsuchiya, please.
Thank you so much. Your kind introduction, Professor Kato. Good afternoon, everyone. It's a great honor for me to give a presentation at a wonderful meeting. I really appreciate Professor Ueno, organized committee, and Ezai. And of course, I really appreciated Professor Omata. And I apologize, my voice is not good, but I completely okay. So let's start my presentation. So I focus on the positioning of lenvatinib in the oral practice. This is my disclosure. I have divided my presentation into 3 parts. At first, I present a new treatment strategies for patients, especially with intermediate ACC. After that, I show the real-world outcome of lenvatinib plus TACE at our institution. And finally, I will introduce the data lenvatinib after immunocombination therapies. Let's start new treatment strategies for patients with intermediate stage HCC. And today we can use 8 regimens for patients with unresectable HCC. The purple is the first-line therapy, and from 2020, we can use immunocombination therapy. The Professor Kudo proposed the goal of the BCLCB-HCC was clinical CR and drug-free using lentase or ABC conversion therapy. So I introduced the result of TACTICS-L trial. The TACTICS-L trial is a phase 2 prospective multicenter single-arm study performed in Japan. It's a TACE is scheduled. First TACE is scheduled, and lenvatinib was administered for 14 to 21 days prior to the first TACE. And after prior TACE, TACE was performed on demand. And this is the basement characteristics of the patient. So actually, the half of the patient was BCLC-A, and 54% of the patient was BCLC-B. And the patient beyond up to 7 criteria was 35%. It's a rare data. I think it's very important for the clinicians. So let me focus on the relative dose intensity of lenvatinib. So relative density of lenvatinib is very important in the real-world practice. So before TACE, the median RDI of lenvatinib was 100%. But however, after TACE, the relative dose intensity of lenvatinib was only 47%. And the duration of lenvatinib is also very important. And after TACE, the median duration of lenvatinib was 10 months. So thinking about the result of the trial, we tried to give the lenvatinib to the patient on the full dose before TACE, but after TACE, we don't have to give the full of the lenvatinib after TACE. And the duration of lenvatinib is almost 10 months. It's a PFS. The median PFS of the trial was 28 months, and overall survival, median overall survival was not reached. And this data is also very important. It's a subgroup analysis of the responders. So when we focus on the relative dose intensity of lenvatinib, so before first days, the keep the maintain the full dose of lenvatinib was significantly associated with response or CR. However, the relative dose intensity of lenvatinib after first days was not significantly associated with the response or CR. So the relative dose intensity of lenvatinib was different between before taste and after taste. So it's the data of the safety profile. There is not so many grade 3 adverse events, and most of adverse events are manageable. I introduced the other lenvatinib plus taste trial. It's a launch study. The study was performed in China, and it's a prospective randomized control study on taste plus lenvatinib and lenvatinib. The left side, you can see the baseline characteristics, and compared to the TAXIX trial, the patient in launch study was a very advanced patient. The 71 patient had macroscopic portal invasion, and almost half of the patient had extrahepatic split. On the right side, you can see the subgroup analysis. So importantly, the patient with and without extrahepatic metastasis, lenvatinib plus TACE was the both better prognosis in patient with or and without extrahepatic metastasis. So we can perform lentase in patient with extrahepatic metastasis. So this slide showed the adverse event in the launch study. There is no significant, the not manageable adverse events. So the clinical question is how to choose lentase or atezolizumab plus bevacizumab in real-world practice. To find the answer, I looked at data from the nationwide observational multicenter study of lenvatinib performed by Japanese Red Cross Liver Center Group. We collected the data, the patient treated with lenvatinib. The patient number was 343. The median age was 73, and BCLCP patient was 44%. So it's about survival and progression-free survival. So the patient with BCLC stage B, first line lenvatinib with very good liver function. In such patient, the median overall survival was 25 months, and the median progression-free survival was 1 year. We analyzed the prognostic factors in patients treated with lenvatinib. The factor is performance status, liver function, and tumor markers, AFP, and macrovascular invasion. And Dr. Tada at Himeji Red Cross Hospital and already reported neutrophil to lymphocyte ratio, and NLR is associated with survival in patients with unresectable ACC treated with lenvatinib. The patient with higher NNR or had a poor prognosis. So he's Naoki Uchihara. He's a my colleagues, and the presented the data, the morning session. We analyzed the factors associated for progression-free survival during lenvatinib in patients with BCLCB up 7 out. In first-line patient, in multivariate analysis, the liver function and CRP were significantly associated with PFS. So thinking about the result, key factors for lenvatinib therapy in BCLC or in all patients is liver function, NNR or CRP, and performance status and AFP. If the patient has good liver function, low NNR and low CRP, and good performance status and low AFP, lenvatinib works and showed a really excellent prognosis. So let's move to the real-world outcome of lenvatinib at our institution. This data was made by Dr. Uchihara. He's a very talented young doctor. We are happy to work with him. And the patient number was 31, and we classified the patient into 3 groups. A group was performed tests to achieve CR on demand. The B group is to perform tests to achieve PR or CR on demand. And C group is we schedule tests and lenvatinib started before tests. It's a tactical method. You can see the baseline characteristics. And group A and group C, all patients are BCLC-B patient. This slide showed the OS and PFS. The median observation period was 17 months, and the median overall survival was almost 14 months, and the median PFS was 22 months. And this slide showed overall survival according to BCLC stage in Group B. And Group B means to perform tests to achieve PR or SD on demand. So in patient with BCLC-B, the median overall survival was 41 months. One of the good reason of the perform the lentis is we can perform sequential therapy after lentis. Only 3 patients moved to the best supportive care, and most of the patients could receive the other molecular target therapy after lenvatinib plus TACE. I can show one case, and he's a 70s male, and background liver disease, alcoholic, and good liver function. And the first therapy is resection. But after 1 year after the resection, and he had a multifocal recurrence bilobular, but his liver function was preserved and he had low AFP, so we decided to lentis. So it's the group C was scheduled TACE, and we started lenvatinib before TACE, and it's a full dose of the lenvatinib. So after TACE, we could modify the lenvatinib because RDI of lenvatinib was not significantly associated with the responder or CR in TACTICS-L trial. And we stopped the lenvatinib because she achieved the clinical CR, and we only observed now. So let's move to the lenvatinib after immunocombination therapies. So it's a JSH guidelines already presented by Dr. Hiroshima, and we can perform the two types of the immunocombination therapy as first line. So Dr. Aoki at Kindai University already reported the lenvatinib therapy in patients with who failed to the first-line immunocheckpoint inhibitors. As a result of the study, the median PFS was 10 months, and lenvatinib after checkpoint inhibitors relatively good treatment result. The next, the other study is heritage study. It's presented by Professor Asaoka as a ASCO GI. And from 2020, we Japanese doctors use atezolizumab plus bevacizumab as first-line therapy. The point of the second and third line, after atezolizumab plus bevacizumab, we Japanese doctors often use lenvatinib after atezolizumab plus bevacizumab. And the DCR was 80% with RECIST criteria, and median treatment duration was 87 days. So it's a multi-center study, international multi-center study. The patient number was 464, the atezolizumab plus bevacizumab, and the data of the second line therapy is 233. It's all about survival from the beginning of the second line after atezolizumab bevacizumab. The patient who received lenvatinib after atezolizumab plus bevacizumab, in such patient, the median OS was 17 months, and lenvatinib has significantly better prognosis compared to the other TKIs. And it's data from our hospital. The patient who received atezolizumab plus bevacizumab as first line, we use the lenvatinib as a second line. And the induction rate of molecular target therapy and 77% in atezolizumab plus bevacizumab. So we use lenvatinib after atezolizumab plus bevacizumab. The patient number was 23. And the median age was 73, and this is overall survival in lenvatinib therapy from the end of atezolizumab plus bevacizumab. The median overall survival was 15 months. The best response according to the, we focus on the proteinuria. The UPCR over the more equal or more than 2 is unfortunately there is no objective, no patient who could achieve ORR. However, if the patient with low UPCR and ORR was 25% and DCR was 87%. And we collected data on the second line lenvatinib after atezolizumab plus bevacizumab. The patient number was 54, and according to the RECIST criteria, ORR was 17% and the DCR was 72%. And we focus on the, again, proteinuria. So the patient with the less UPCR, and according to the RECIST criteria, ORR was 20% and DCR was 73%. However, if the patient with high UPCR and severe proteinuria, so ORR was 0% or MRECIST only 17%. So I think the management of proteinuria during the first-line therapy, atezolizumab, bevacizumab, is very important for the, of course, very important for the first-line therapy and also important to the sequential therapy. Let's move to the steroid regimen. We performed the steroid regimen in 21 patients. Most of the patient was BCLCC, and 81% of the patient was BCLCC. There is a logical response of the steroid regimen. The patient who received the steroid regimen as first line to as third line therapy, the patient number was so small, but the ORR was 22% and DCR was 66%. It's similar to the Himalaya trial. So we performed the subsequent therapies after the steroid regimen. So, and the sorafenib, cabozantinib, and lenvatinib, the other molecular target therapies. I showed one case, and the case, the patient is 60 male, and the first line therapy, first therapy is initial therapy was radiofrequency ablation, and unfortunately, and after 3 years, the patient showed a peritoneal metastasis. So we started sorafenib, regorafenib, atezolizumab, lenvatinib, cabozantinib, and this year we started the steroid regimen. This slide showed a clinical course, and the patient once achieved the stable disease by steroid regimen, but after 4 months, the disease was progressed, and we restarted the lenvatinib, rechallenged the lenvatinib. So AFP was decreased after the initiation of the lenvatinib. And Dr. Hagiwara already reported the improved tumor response, the lenvatinib rechallenge after the immunocheckpoint inhibitors. And so the second line after the immunization therapy, there is no evidence or big data. And TKI would be key agent after first line immunotherapy. In conclusions, lenvatinib showed certain effects outcomes in real world practice. Liver function, performance status, NLR CRP, and AFP are carefully evaluated in BCLCB treated with systemic therapy. So we can choose lentase or atezolizumab based on the data. So lenvatinib is one of the key agents after first-line immunocombination therapies. Thank you for your attention.
Thank you, Professor Tsuchiya, for excellent presentation using own data. Any comment or question? As you said, lentase is a very attractive option for the patient. But which is better, do you think, scheduled TACE or on-demand TACE after lenvatinib treatment?
Thank you for your question. Actually, if we can, the scheduled TACE, the tactics L is very attractive because the patient, according to the result of the tactics L trial, the patient only received lenvatinib at 10 months, and we can stop the systemic therapy. Yeah.
Okay, scheduled TACE is sometimes preferable than on-demand TACE, but also I'd like to ask you, you have mentioned that after IO treatment, second line lenvatinib treatment is very effective. And also this is in our institute, the same result we can get. But now we have another option of IO, namely durvalumab tremelimumab. So position of lenvatinib is change or no change? For example, first line IO, still second line is TKI is better, or after the combined IO treatment, The second line treatment IO is possible. How do you think about the which sequence is better, IO TKI treatment or IO treatment?
Thank you for your question. I think there is no so many data after the first line immunocommunity, but we have the data, the nivolumab plus ipilimumab after the second line therapy, and the response rate ORR was nearly 20%, and the data is not so excellent compared to the second line lenvatinib. So I think we can choose the lenvatinib or other immunocombination therapy based on the patient situation. If the patient had a severe proteinuria, we can choose the
That's right.
immunocombination
Yeah.
therapy.
Thank you. And any comment or question? Okay. Still, we have a little bit time, so any question or comment? My last question is very interesting case of re-challenging lenvatinib. That's a very attractive option for the patient. But still, now we have, as you know, 8 regimens. So after using all the regimens, re-challenge sometimes we have to do so. But before using all the regimen, when we retry the same drug for the patient after PD?
Thank you for your question. To be honest, I didn't like the challenge,
Okay,
but because as you said, we can use 8 regimens, but the Dr. Ueshima and Professor Kudo at Kinda University showed the data of the re-challenging of the lenvatinib, and they told me that the point is the first response of lenvatinib. The patient who have the good response at lenvatinib as first line, so first line or the initial lenvatinib of the response of initial response was good. They tried to re-challenge, but the patient didn't respond to the lenvatinib. They didn't re-challenge. It's I think it's reasonable.
Thank you, Professor, for Tsuchiya, for a very instructive presentation. Thank you. So now the time has come, so I'd wrap up this session, Luncheon Seminar 1. Thank you for all audience and also Eisai Company for giving us such opportunity. Thank you.
Thank you very much, Chair and lectures. We'd like to kindly ask you to bring the empty lunch boxes to the exit and hand it to the staff. Thank you.